typically the way the trial is done is that we follow patients for survival, but that takes a long time. It slows the trials down, and it makes it much harder to get answers to our questions. So, one thing that investigators have been looking at is, can you use this decrease in circulating tumor cells as a clinical endpoint in a trial, so that rather than looking at, say, something like survival, does changes in circulating tumor cells correlate so tightly with survival that therefore you can almost use it as a substitute, as a surrogate? And so there has been one trial that was done that really sort of retrospectively showed that it is a surrogate, and now there are going to be additional trials going forward with circulating tumor cells embedded into the trials to really sort of definitively establish that you can use those changes as a surrogate for overall survival, and therefore really expedite trial development. The other exciting area of development has been using changes in the androgen receptor to understand if tumors will still respond to hormonal therapies, specifically drugs like enzalutamide or abiraterone have really sort of become routine part of practice with men with castrate-resistant prostate cancer. And what's been shown very elegantly now is that the response rate, although perhaps not zero, but close to it, is present when patients have a mutation in the androgen receptor. In other words, cells with mutation in the androgen receptor don't respond to hormonal therapy. So that would be an important thing to know right up front, and also potentially is an important mechanism of resistance, and therefore you'd want to go ahead and, for instance, use another form of treatment, chemotherapy, right? So those studies have, so the first generation of those studies has been completed, but now there's sort of additional confirmatory studies that are going on to really sort of understand the best, how useful is this marker, and also the best way of assessing it across different platforms.